Good morning, everyone. Welcome to the City Bar Association panel on the New York Health Act and single payer. Thank you all for braving the cold to be here today. And thank you to the Health Law Committee and the Insurance Law Committees for sponsoring this event. Before we get started, I just want to take a moment to introduce our panel. To my left is New York State Assembly Member Richard Gottfried, who represents the 75th Assembly District covering Chelsea, Hell's Kitchen, Murray Hill, Midtown, and part of the Lincoln Center area of Manhattan. He's the lead Assembly sponsor for the New York Health Act to create a universal, publicly funded, single-payer health plan ensuring health care for all New Yorkers. He's a leading state health policymaker not only in New York but also nationally. He was a major architect of New York's landmark managed care reforms and continues to fight for stronger consumer and provider protections and public support for universal access to quality, affordable health care. His legislative work includes the passage of the Child Health Plus program, health care proxy law, simplification of enrollment in publicly financed programs, HIV testing and confidentiality laws, legalization of medical marijuana, and promotion of stronger primary and preventative care and formation of accountable care organizations. In the legislature, he has been the leading proponent of patient autonomy, especially in end-of-life care and reproductive freedom. After Brian McGovern, our chair of the Health Law Committee, who will be acting as moderator for today, is Bill Hammond, who's the director of health policy at the Empire Center, an Albany-based think tank focused on New York State. Bill tracks developments in New York's healthcare industry with a focus on how decisions made in Albany and Washington affect the well-being of patients, providers, taxpayers, and the state's economy. Before joining the Empire Center in 2016, Bill spent almost 3 decades in newspaper journalism, most recently as a columnist and an editorial board member at the New York Daily News from 2005 to 2015. Hammond was previously on the staff Mr. Hammond was previously on the staff of the New York Sun, the Daily Gazette of Schenectady, and the Post-Star of Glen Falls. His work has appeared in the Wall Street Journal, Politico New York, the New York Post, City and State, the Albany Times-Union, the Buffalo News, and the 74. Next, we have Dr. Oliver Fein, who's a professor of clinical medicine and clinical healthcare policy and research and associate dean for affiliations at the Weill Cornell Medical College. As Associate Dean, he's responsible for Weill Cornell's academic affiliations and its Office of Global Health Education. He is committed to diversifying the clinical education of Weill Cornell medical students by getting them off the island of Manhattan into the South Bronx, Queens, and Brooklyn. His global health work extends this effort by helping students with international rotations around the world and placements in poor, minority, and immigrant communities in New York City. He's a practicing general internist with experience in health policy and a commitment to access to care for vulnerable populations, health system reform, and global health education. Dr. Fein received his medical degree from Western Reserve University in 1967 and completed his internship at Cleveland Metropolitan General Hospital and his residency at Lincoln Hospital in the Bronx. In 1993 and 94, he was a Robert Wood Johnson Health Policy Fellow in the Office of the U.S. Senate Majority Leader George Mitchell, and in 1995 he came to Weill Cornell Medical College as Associate Dean for Network Affairs and subsequently was appointed Associate Dean for Affiliations. Next, we have Ashley Fox, a professor in the Department of Public Administration and Policy at University of Albany, SUNY. She is a lecturer in the Department of Health Evidence and Policy at Mount Sinai School of Medicine. She earned her bachelor's and master's in political science from the University of Connecticut and a PhD in sociomedical sciences from Columbia University. She was a postdoctoral fellow in the Department of Global Health and Population at Harvard between 2009 and 10, and at Yale in the Division of Health Policy and Administration between 2010 and 11. Her research focuses on the politics of health policy and the effects of policies on health outcomes, including not only policies targeted at health, but also broader social policies that have indirect effects on health. Her research has examined global HIV/AIDS policy and epidemiology, including better specifying the role of what is often described as political commitment and explaining differences in countries' policy responses to the disease. Her theoretical interests concern the role of public policy, party ideology, and descriptive representation in public policy making. She's a widely published academic, including on different models of universal health care coverage. And finally, we have Eric Linzer, who's the president and CEO of the New York Health Plan Association, an Albany-based organization that represents 26 health plans in New York State. These plans provide comprehensive health care coverage to more than 8 million New Yorkers. As the chief executive of the Health Plan Association, Eric is responsible for development of policy positions for the organization, advocacy, and the executive and legislative branches of government, and serves as lead spokesperson to the media and the public on issues relating to the managed care industry. Eric came to the Health Plan Association from Massachusetts Association of Health Plans, where he spent 15 years. Eric holds a JD from Suffolk University Law School, a master's degree in political science from Suffolk University, and earned his bachelor's degree from Boston College. In 2019, Eric was named to the City and State's inaugural Health Power 50, listing the 50 most influential leaders in the health sector. He's also a past recipient of the Massachusetts Medical Law Report's Leader in Quality RX for Excellence Award. So without further ado, I will turn it over to, I think, Brian. Kick things off.
Thank you, Allison. Before we actually hear from the panelists, we thought it would be helpful to provide an overview of the New York Health Act, starting with a brief history of the legislation and its current status, and then we can discuss some of the more salient provisions of the bill. Assemblymember Gottfried first introduced the New York Health Act, providing for single-payer universal health plan in New York in 1992. The Democratic-controlled New York State Assembly passed the bill in the past 4 sessions, but that bill has died each year in the Republican-controlled Senate. With the November 2018 election results, the Democrats are now in control of the state Senate as well as the Assembly, and the prospects for passage of the legislation by the full legislature has improved. The new chair of the Senate Health Committee, Gustavo Rivera, is a co-sponsor of the New York Health Act in that chamber. For his part, the Governor Cuomo has previously remarked that any form of universal health coverage should be addressed at the federal level. And more recently, in this year's budget bill, the governor has proposed establishing a commission to study universal access to health care and to report to the governor on possible options for achieving universal access, and that report would be by December 1 of this year. Among the options the committee would be charged with considering is strengthening New York's commercial insurance market. Assemblymember Gottfried has, as well as the Physicians for National Health Program, have condemned that proposal, while the insurance industry and other opponents of single payer have applauded the proposal for a commission. So that's the current status of the bill, and Assemblymember Gottfried will have a chance to correct any statements I make, while I now provide a summary of what we think are the key provisions of the New York Health Act. And as Allison opened with, the legislative intent behind the New York Health Act is to create a universal single-payer health plan, the New York Health, that would provide comprehensive health coverage to all New Yorkers. So what would be the benefits and coverage under the New York Health Act? It would be essentially as comprehensive in scope as the benefits covered or required under existing public plans, Medicare, Medicaid, Child Health Plus, as well as under the New York Essential Plan and qualified health plans offered on the health exchange created under the Affordable Care Act. So the New York Health Plan would include and cover physician services, hospital care, nursing home care, and skilled home care, among others. Although the bill contemplates developing a proposal for coverage of long-term care benefits within 2 years of enactment, I believe the bill's sponsors have indicated that they intend to introduce an amendment to the bill that would include long-term care as a benefit from the outset of implementation of the New York Health Act. So here is the core of the New York Health Act. Under the oversight of a 26-member Board of Trustees, the Department of Health would be the state agency responsible for administering the New York Health Plan. And under the New York Health Act, all employer-sponsored or commercial insurance would be essentially replaced by coverage under the New York Health Plan. As envisioned in the New York Health Act, the Commissioner of Health would seek to obtain Medicaid state plan amendments and/or waivers from the federal government, and that would be from the Centers for Medicare and Medicaid Services, in order to integrate into the state's single-payer plan all of the benefits that are now covered to eligible beneficiaries in New York State by Medicare, Medicaid, and the ACA plans, and would seek to draw upon and maximize federal financial participation and other federal dollars now used to fund those programs and to help pay for coverage on the New York Health Act. As we understand, though, the bill's sponsors are proceeding on the assumption that the state will not receive those CMS waivers and approvals, at least under the current administration. So the scope of the New York Health Act would be commensurately more limited. And while the New York Health Act would create a single-payer system operated by the state, the act would prohibit private insurance companies or health plans from offering insurance coverage for any of the benefits that would be covered by New York Health. The act would allow a governmental or not-for-profit entity that is either an accountable care organization or a Taft-Hartley plans established through collective bargaining to serve as a, quote, healthcare organization, and that could administer plan benefits instead of DOH, Department of Health, if a member chose that option. However, a for-profit entity would not be allowed to serve as a health care organization. So there would be essentially no continued role for private insurers in New York State, at least with respect to coverage of New York State residents, other than to offer coverage for whatever limited benefits, such as dental, that would not be covered under the New York Health Act. And the New York Health Act provides for a health trust fund that would be established to pay for health coverage under the New York Health Plan. And that fund would provide dollars or funding to the Department of Labor, State Department of Labor, for job retraining and placement assistance for those employed in the health insurance industry who would be displaced by the New York Health Plan. So assuming there's no federal financial participation or other federal support, the New York Health Act would be entirely financed with state taxpayer dollars. That would be a combination of progressively graduated payroll taxes, 80% to be paid by the employer, 20% by the employee, and similarly progressive taxes on individual income other than ordinary income, including interest, capital gains, and dividends, as opposed to wages or salaries. So members, residents of the New York State, covered by the New York Health Act, would not be required to pay any out-of-pocket cost-sharing amounts for their health care. There would be no premiums, no deductibles, and no coinsurance. Now, the New York Health Act anticipates a potential impediment under the federal ERISA statute, which regulates and preempts state regulation of employer self-funded health plans. So the issue is addressed in the bill by providing the issue addressed in the bill concerns the provision of a single-payer health coverage that replaces employer-sponsored coverage and imposes a payroll tax when it comes to out-of-state employees of New York State employers. So the bill provides for a provision for a credit, that would pay for the comparable coverage under the New York Health Act. So in any event, the New York Health Act does provide for severability of the New York Health Act in the event that any portion of the act is deemed invalid or in violation of ERISA. It also provides more generally a severability clause, which I believe is a standard provision that would protect the continued effect of the Act should one or more provisions be declared invalid. So one of the questions often comes up is how would the New York Health Plan impact the delivery of health care and reimbursement for the health care providers that participate in the New York Health Plan. So each member, that's the resident covered by the plan, would have to select a care coordinator who could be a physician, a home care agency, or healthcare organization. But the member would not be required to obtain any prior authorizations from the care coordinator to access services under the New York Health Plan, and could choose any willing healthcare provider licensed and qualified to provide the services. And the New York Health Plan likewise would not limit the network of providers from which or from whom the member could access care and services. So how would healthcare providers be paid or reimbursed for providing services covered by the New York Health Plan? So initially, the health plan would provide reimbursement on a fee-for-service basis. And the standard for reimbursement codified in the New York Health Act would be rates that are, quote, reasonable and reasonably related to the cost of efficiently providing the healthcare service and assuring an adequate and accessible supply of the healthcare service, close quote. So, healthcare providers can include proprietary entities and obviously private physicians and medical practices. However, the rates of reimbursement to be provided would not provide for any return on investment or profit associated with healthcare services covered by the New York Health Plan. Additionally, the New York Health Act provides that the plan may provide for reimbursement of capital expenses for what are referred to as Article 28 facilities, hospitals, nursing homes, or diagnostic and treatment centers. But those eligible for the capital reimbursement would be limited to governmental and not-for-profit entities. So while the Act contemplates fee-for-service to be at the outset, it provides for promoting a movement away from fee-for-service toward alternative payment models, such as global or capitated payments, as well as value-based payments and preventative services, although there's no timetable in the proposed statute for implementing those alternative payment methodologies. The Healthcare Act would also encourage collaborations among otherwise competing providers under the standard, under the active supervision of the Commissioner of Health, in order to advance goals of improving the quality and access to health care. In this regard, the Act provides for, quote, state action immunity under the state and federal antitrust laws to healthcare providers, particularly with respect to their relations with the single-payer New York Health Plan created by the New York Health Act. The New York Health Act also establishes the right of healthcare providers to basically get together and collectively bargain through a representative with the New York Health Plan over rates of reimbursement and payment methodologies. But the New York Health Plan would be allowed to offer different terms and conditions to those competing healthcare providers. And as noted, there is a separate, there's a specific severability clause for any court ruling that any portion of the act is in violation of antitrust laws. The remainder of the statute would remain in effect. That's just a belt and suspenders provision that's common among other initiatives of this nature. So when would the New York Health Act and when would the New York Health Plan become live? Well, the Act by its terms would go into effect immediately upon enactment. However, before a single-payer plan would actually be operational, the state would have to develop a revenue plan with the establishment of marginal tax rates and tax brackets necessary to generate a sufficient level of funds to administer and to pay for the comprehensive healthcare services covered by the Act. The state would also have to create the administrative infrastructure at the Department of Health, the offices, the personnel, and the operational policies and procedures, as well as regulations as necessary to implement the single-payer system. And there is no prescribed timeline for implementing the revenue plan and the other operational aspects in the Act. So that is an overview of the New York Health Act. It has many other provisions, but we thought we would try to distill the discussion to what we consider to be the more salient provisions. So now we'll hear from each of the panelists, who will basically provide their own opening remarks on the New York Health Act, why adoption of a single-payer system would be or would not be in the best interest of New York and New Yorkers, why they believe the New York Health Act in particular should be the model adopted in New York, and what, if any, alternative reforms or systems might be appropriate or more desirable. And the latter point will be certainly a topic of a discussion in the debate and discussion section after each of the panelists has a chance to give their opening remarks. So our first speaker, our first panelist to speak will be actually Professor Ashley Fox. Professor Fox offers a different perspective from the others in that she has an academic interest and expertise in single-payer and single-payer models and the various alternatives to single-payer that have been implemented in other countries or tested in other states. And so with that, we'll kick off the opening remarks with Professor Fox.
Thank you very much, Brian, and thank you everybody for coming out. So I've been given sort of a tall order here. I'm supposed to talk about sort of what's wrong with the health system that we have right now. You know, why do we need further reform? Do we need further reform? As well as talking about different models of universal health coverage and sort of introducing the different models that are out there, as well as talking about what happened in Vermont. So I was involved as a consultant during Vermont's single-payer health reform when I was a postdoc at Harvard. So I have some experience with that. And then we've also been asked to talk about, you know, alternative models and ways forward. So that's a lot to do in 8 minutes, but I'm going to do the best that I can here to sort of convey main points. I did distribute some slides, which I'm not going to get to touch on everything, but if there's something I don't get to touch on, you can see it in the slides. So first of all, I think in terms of, you know, where are we right now with health reform and you know, do we even need further health reform, right? Didn't the Affordable Care Act solve our problems? Well, I think, you know, it definitely made some inroads in certain areas, right? So our uninsured rate now is around 9% compared with 15% before the Affordable Care Act. And so that's one of the big feats of the Affordable Care Act. And, you know, it would have been even lower had we actually fully implemented the Affordable Care Act, especially the Medicaid expansion, which, you know, we did not. And obviously now that act is also sort of being kind of systematically dismantled. So there may be people losing some health insurance that they may have gained. But the bigger issue that I think is really important and why this issue continues to be on the agenda is the healthcare spending in the U.S. So the big thing or issue that the Affordable Care Act did not address is just how expensive healthcare is in the U.S. and the rate of what is known as cost inflation. So the cost of healthcare is just going up at a very rapid pace. And, some of the evidence of that is contained in the slides. We spend on average double what other countries spend on on their healthcare per capita and as a percent of GDP. There's a slide that sort of shows just how out of sync we are with other countries. Other countries are experiencing cost inflation as well, but our rate of cost inflation is much, much higher. So, that sounds kind of abstract, cost inflation, who cares? But that has a real impact on everyone's lives. So both for individuals in terms of, how much money we have to spend, that's not going to healthcare, as the government. So, when the government has to spend more on healthcare, it has less money to spend on other things like education, and even employers. And I think this is really a key issue that a lot of people have overlooked, is that, this is actually good for business. Getting, removing sort of the employer-sponsored health insurance part of this from off the backs of employers would actually save employers money at the end of the day. There's a slide in here that shows that presently the average health plan for private employer-sponsored coverage is about $18,000 a year. The employer pays the lion's share of that. And that's nearly tripled since 1999. So, the cost to employers of paying for their employees' health care is a big burden. And so what is different about the U.S. from other countries, and why is our healthcare so expensive? The main reason, really, that health policy analysts have sort of, if they can agree on anything, that they agree, it has to do with the way that our healthcare is organized. And we're the only high-income country that primarily relies on employer-sponsored coverage. So 56% of people get their health insurance through a private healthcare plan. Most of them, 49%, through their employer. Another small percentage buy their health care on the private marketplace, so they don't get subsidized by their employer. That's why it's so expensive for them to buy the health insurance plan on the private marketplace. Another 36% of us get our insurance through some kind of a public system. And so we have this kind of hybrid model that's very decentralized, not coordinated. And that's largely what drives up the costs. So every other country has some form of universal health coverage model, which enables them to enact certain cost control measures that sort of bring the costs more under control. So very briefly, there's three major models of universal health coverage that other countries utilize. And so what we're talking about here is one of them, single payer, as it's often known. But I will mention briefly that there's two other common forms of universal health coverage. And so one of the major models is a national health service model. This is what they use in the UK. This would be the most sort of socialized healthcare model, and is not what we're talking about in terms of the New York State Health Act. That is essentially, it's the most public of all the options. The analogy I always give in class is it's similar to our public education system. It's primarily publicly financed, usually through general tax revenue. At least at the hospital level, providers are salaried employees of the state, much like teachers are salaries employed of the state. So that's the most kind of socialized health system that we have. The Veterans Affairs would be the equivalent in the US. It works the same way, but that's not what a single payer model is. A single payer model, I actually think, is better. I prefer the term national health insurance plan because I think that better describes what it really is. It's basically one health insurance plan that everybody has access to. So we sort of decide, okay, this is going to be a basic plan. You're going to pay into it usually through a payroll tax. So it's an earmarked tax, and the equivalent we have in the US already is Medicare, right? And so that's why it's also known as Medicare for All. So this should be a familiar model to most people. A third model which is actually one of the most common model, is a regulated multi-payer model, sometimes also referred to as social health insurance. That, in a sense, is actually closest in character to what maybe we're more familiar with, where you have sort of competing insurance plans, but with some key differences. The key differences being that in most countries that have this, Germany being the ideal type case, these insurers are not for profit, so they cannot be for profit. They are very highly regulated, so they have to offer a certain amount of benefits. They can compete, but on very limited terms. And it's also sort of more pooled and financed through payroll taxes in a way that is somewhat different from what we're familiar with. So those are the three major models. In terms of kind of how these models compare on performance, again, in the slides, there's some summary statistics. Basically, in looking, I was interested in just sort of, is there any evidence that single payer performs particularly better than these other, universal health coverage models? And how do any of these universal coverage models compare to the US? Basically, what I found through just looking at some, country level comparisons is all of these models perform better than the US on pretty much any better or the same on pretty much any indicator that you look at. So just to point out a few sort of, I think, common misconceptions that we often hear about any kind of universal coverage plan is, wait times will increase, care will be rationed. The comparative evidence does not support that. In other countries, people are getting just as much care, even more care often than we get in the US. Wait times are either less or equivalent in all categories except for in certain elective surgeries. And even there is a very country by country issue. And in particular, what I noted from my analysis is that Canada really stands out as having high wait times for elective surgeries. We often make the comparison to Canada because that's the single payer system we're most familiar with. But that doesn't seem to be emblematic of single payer systems overall. Another point that I think is important to raise, as has already been sort of brought up in the discussion of the New York Health Act, is what was interesting to me in looking at these different systems is that in most single-payer systems, a large portion of the population actually gets some private supplementary insurance. So for things that are not covered in the basic plan, majorities of the population actually do seem to purchase private insurance. So I think that's important because of these questions or arguments about, well, what's going to happen to private health insurers if we were to implement something like this? And I think one answer is that there are opportunities in a private, health insurance marketplace to still, have some private plans. There are issues, of course, with, if people start relying on that too much, then people are sort of double paying, right? If you pay by taxes for your single payer plan, and then in addition, you have to buy a supplementary plan. So you want to be careful how you design that, but it sounds like that a lot of attention has already been given to that in the New York Health Plan. So I guess just I want to touch also just quickly on sort of what happened in Vermont. I think that people were people who were in favor of single payer were very excited about that, and then that's also been sort of used to say, oh well, maybe this isn't going to work. My own sort of analysis of what happened in Vermont. Well, first of all, actually, before I get to that, really briefly, I just want to say there's a few issues that get raised in relation to, can we do this at a state level, right? Like, can this even work at a state level? And so what we encountered in Vermont were several sort of technical issues that pose challenges to doing this at a state level. I would say that overall, I don't think that, we didn't conclude that these were insurmountable, but there certainly are considerations. So, for instance, having to get waivers, as was mentioned, from Medicaid and Medicare. Medicaid, there's much more precedent for getting waivers. New York State already has many Medicaid waivers. There's not really a precedent for getting a Medicare waiver, but it sounds like there's a plan to not need to get a waiver. And I think if we can accept that we're going to have Medicare and a state single payer plan, then, that doesn't seem to be an issue. Another issue is ERISA, which was raised. Our research on this when we were looking at Vermont was, first of all, there's a question of whether ERISA would even apply. There's questions about that. You guys are lawyers, so you would probably know much more about this than I would. It was concluded that maybe there would be a court case, but that who knows what would happen as a result of that. But certainly that ERISA was not an insurmountable issue. Another issue that I think is important to think about is what would happen to plans or companies that work across state lines or are multinational, and what would happen to people that work in New York and are employed by an employer in New York, but live outside of New York. That was something that came up in Vermont, but I think was less of an issue in Vermont because there's not as many people that would affect. But in New York, I used to live in Connecticut and commute in and work at Mount Sinai. What would happen to me in that instance? So there's some technical questions about how this would work. I will note that, it's not unprecedented for things to start at a state level and then, spread beyond the state level, right? So in Canada, single payer started in Saskatchewan province and later became the national policy. The Affordable Care Act was, originally implemented in Massachusetts and, then became the model for the national reform. So there is a precedent for this. What went wrong in Vermont, basically at the end of the day, I think it was just that the governor was never fully committed to actually doing this. He sort of instrumentally, maybe if I'm being cynical for political reasons, really championed single payer, but was never really fully behind it. And so when the financing plan came out and it looked like, oh, this is going to increase taxes, it was sort of a way for him to say, oh, well, actually, we're not going to do this. And I think part of the issue there was putting off the financing until after the bill was actually adopted. So I don't think inherently per se there's any reason why a single payer plan couldn't work per se. I think there's a lot of fear involved whenever there's a big change. And, especially, the research in behavioral economics shows that loss aversion is, a very big, motivator for people. So this just sort of fear of, oh no, if I lose choice in my insurance plan or, this big change is coming, I might lose something. That's a way to sort of say that this isn't going to work. But I don't think based on cross-national experience that, we can conclude that this couldn't work in the U.S. And then just last thing on, compare, like what other alternatives are there, right? What else could we do? Why do we have to do single payer or can we do something else? I think some options that people are looking at, one would be kind of a more incremental approach to health, maybe kind of towards a single payer, but not quite a single payer, so like a public option. That was something that was part of the Affordable Care Act and then was dropped where you could, buy into Medicare. And people have looked at doing that at a state level. That was considered, in Vermont as well. Or doing things like lowering the age of eligibility for Medicare so that more people could be eligible for that and raising the income eligibility threshold for Medicaids to make, sort of condense that middle ground of people that, and expand eligibility for public programs. I think the downside of those is that because they wouldn't be universal, the question of how do we pay for it is actually more salient. Because they wouldn't, it wouldn't be everybody paying in and everybody getting back. You still have to find a way to pay for that. With single payer, there's a lot of, fear about, oh, well, it's going to double the budget of New York State. It's going to cost so much in taxes. That's true. But again, we have to remember that we're not going to have to pay that expensive private healthcare premium that we're already paying. So they're actually, even just, by merely replacing with tax money what we're paying in private premiums, there will be an immediate cost savings from that. Another option is obviously a regulated multi-payer plan, and that was back in the 90s, actually under Clinton, the bill that got rejected was essentially a regulated multi-payer plan. I think there's a lot of advantages to that, but I also think that, again, in terms of the cost savings, the cross-national evidence does not suggest that there's going to be. There would still be cost savings, but it's not as substantial as under single payer. And some people criticize single payer saying, oh, well, in the US, it's not going to work because interest groups are going to influence things, too much. I actually think there's more risk of that with a regulated multi-payer plan, because where these plans work really well are in countries that have existing centralized wage bargaining agreements, like corporatist regimes, not to get too academic-y, but they work very well in that context, and we don't have that in our context. And then finally, I think one issue that we're left with is, what are our other alternatives? We just saw from the repeal and replace efforts that basically the other alternative is more rationing and moving in a more privatized model, and basically just having more competition and maybe even having the market be more involved in healthcare. And I think the problem with that is it just brings us back to basically making healthcare a privilege for people who can afford it. And maybe it would bring down costs, but there's still the issue of access, especially for people that can't afford it or wouldn't get it through their employer. So I know I went over my time, and I apologize, but I'm going to leave off there. Thank you.
Thank you, Professor Fox. That was very informative and useful to provide that context for the later discussion we have with the other panelists. And that next panelist is the bill's sponsor, Assemblymember Gottfried.
Well, good morning. Does everybody in the room have health coverage? Yes? Everybody in the room have health coverage? Okay. You're the people I want to talk to. Because this issue is not primarily about covering the uninsured, who are 5% of New York's population. This is about, they will certainly benefit, but this is about the rest of us. This is about the millions of New Yorkers who have health coverage, who still can't get the care they need, or have to face serious financial obstacles and hardships in order to get it. I don't know anybody who says that that phenomenon is acceptable, but there is no plan on the table other than the New York Health Act that can meet that need. We're talking about real families. The Federal Reserve Board found about a year ago that 40% of American households, and remember, if a few percent of Americans are uninsured, 40% of American households means almost all of them have health coverage. 40% of American households reported that they could not come up with the cash to meet a $400 expenditure if they had to. A few weeks ago, another banking report came out that said that 60% of American households could not come up with $1,000 for an unanticipated expense. That's relevant here because the average health insurance plan has a deductible of $2,700. And that's part of why the Gallup people find that in any typical year, a third of U.S. households that have health insurance have at least one family member who that year had to go without needed health care for financial reasons. And in most cases, it was for a serious health condition. And it's a burden. The burdens of this system, whether it's rising premiums or deductibles that are becoming almost universal and whose cost is rising much faster even than premiums, and copays and restricted provider networks with out-of-network charges, all of those costs are distributed without regard to ability to pay. The insurance company doesn't care whether the deductible hits a multi-million-dollar CEO or the receptionist or janitor. They want the same premium. They're going to impose the same deductible. And it's all dramatically worse if we talk about long-term care, like home care or nursing home care, which for a middle-class family, even an above middle-class family, can just wipe out a lifetime of savings. Part of the problem is that we burn tens of billions of dollars a year in New York State alone. It's hundreds of billions nationally on the bureaucracy and profits that payers consume, which is about 18% of the premium dollar. the administrative costs that healthcare providers have to incur, largely to fight with the bureaucracy of insurance companies, the outrageous prices that we pay drug companies, largely because nobody has the bargaining clout to negotiate lower prices with them. Under a single-payer system, there would be enormous savings. Moving to the New York Health Act, taking insurance companies out of the picture, would save us every year over $20 billion that we now spend on insurance company administration and profit versus what the administrative costs of the New York Health Act would be. $16 billion in administrative costs that healthcare providers spend versus the much smaller amounts they would spend to deal with a single-payer system. We could negotiate $18 billion in savings in what we pay to drug companies, and that number isn't just pulled out of the air. It comes from looking at what Medicaid is able to negotiate, even though Medicaid, certainly in New York, is broken up into a whole bunch of individual privatized Medicaid managed care plans. If we had Medicaid negotiating as a single payer along with all 20 million New Yorkers, the savings would be in the 18 billion ballpark, which brings us to $55 billion in savings. Now, there would be additional spending because we'd be paying healthcare providers more. We would be picking up the cost of deductibles and copays. A lot of what the home care that is now delivered unpaid, in quotes, by family members could now be paid for under the New York Health Act. Put all that together, you get about $44 billion in increased spending, which gives you a net of about $11 billion in savings. Now, the New York Health Act would be replacing $131 billion that we now spend in premiums, about $29 billion that we now spend every year in New York on out-of-pocket spending. It would also pick up the $9 billion local share of the Medicaid program, the bulk of which is, by the way, paid by New York City, but every county in the state bears some of the costs of the Medicaid program. That's a total of existing spending of $169 billion that the New York Health Act would be picking up, but after we have the net savings of $11 billion. So instead of $169 billion, we would be needing to raise $158 billion, which would come from the New York Health Act taxes, which would be primarily levied on payroll. A portion would be levied on non-payroll income like capital gains and dividends and the like, to the extent it is currently subject to the New York State personal income tax. Just a couple of notes about the provisions of the New York Health Act. On the question of waivers relating to Medicaid, Medicare, the Affordable Care Act, yes, the plan would run more smoothly with waivers from the federal government, and we have a whole bunch of Medicaid waivers. New York State has a handful of Medicare waivers that we have negotiated, particularly relating to dual eligibles, Medicaid and Medicare dual eligibles. But the plan can run fully, still drawing down all that federal money without waivers, essentially by running, in most cases, as a wraparound of those federal programs. There are a couple of other mechanisms we could use, but we would not have to give up the federal money that is coming to New York. We would not be limiting the program. One point to clarify on the so-called healthcare organizations that are talked about in the legislation, that is basically another word for accountable care organizations. We came up with a new word because some entities that aren't technically ACOs would be able to play that role. What they would be is essentially not administering the New York Health Act separately, but rather acting as integrated provider networks. They could also do care coordination, although let me stress that in the New York Health Act, by definition, care coordination is not a gatekeeping role. It's not a required referral. It's not prior authorization. It's basically helping you to make sure you can navigate the healthcare system and get the benefits, get the care that your providers have recommended for you. Unlike most other state proposals, the New York Health Act does have a fairly specific revenue mechanism in it. It talks very specifically about a progressively graduated tax, both on payroll income, which would be paid at least 80% by the employer, could be more, probably under collective bargaining, and a similar provision for a progressively graduated tax on currently taxable unearned income. The precise brackets and rates would be determined down the road when we're ready to implement the plan, when we know exactly what income is that year, how it's distributed, et cetera. There is also very specific provision in the bill about cross-border employees. If you work in New York but live in New Jersey, your employer and you would still pay the New York Health Act taxes. We don't want to give employers an enormous incentive to hire only out-of-state people. That would not be nice to New Yorkers. But since they're not New York residents, they would not be getting New York Health Act benefits, just like they couldn't send their children to New York City schools, even if their employer pays property taxes. But if their employer is paying for health coverage for them, or if they are in the other state, that would be deductible against their New York Health Act taxes. Similarly, if you live in New York but work out of state, the bill says if your employer has sufficient contacts with New York to be subject to New York law, then they would be obligated to pay the New York Health Act taxes as if they were located in New York. If they do not have sufficient contacts to be required to pay the New York Health Act taxes, they could either choose to, which if they're an employer who provides health coverage for you, they would probably happily do that because the cost would be significantly less. If bottom line is they don't, then you would be treated, and they're probably not paying for health coverage for you today either, you would then be treated as self-employed and pay the full New York Health Act payroll tax. The basic principles of the bill are, first of all, to stop wasting money on the costs of insurance companies and the costs that they impose on healthcare providers. That feature is essential to making the whole system work. And any proposal that thinks it can help control costs or provide better coverage to New Yorkers that doesn't provide those savings, somebody is kidding somebody. Second key feature is the fact that we would all be in the same boat. Now, for some people, that's important because it's social justice, and I certainly share that sentiment, but it's particularly important because the best way to make sure that the New York Health Act treats patients and healthcare providers fairly and adequately is if we are all in the same boat, so that rich and poor alike all have a stake in the quality of the program. One way to look at that is if the board of the MTA all rode the subway every day, the ride would be a lot better. Yeah, enough said. Final point is that replaces a system that is funded horribly inequitably, without regard to ability to pay, imposing massive costs, both regularly in terms of premiums and deductibles and out-of-network charges, and randomly in terms of if you have a really serious illness. Instead, it would be paid for by a progressively graduated tax based on ability to pay. So to wrap up, as I said at the outset, I don't know anybody who thinks it is right that millions of New Yorkers cannot get the health care they need or face enormous financial obstacles or hardships to get it. And I don't know anybody who disagrees with that proposition or who has a proposal that can meet that need other than the New York Health Act. Thank you.
Thank you, Assemblymember Gottfried. And I think now we'll turn the discussion to Bill Hammond from the Empire Center.
Okay, thank you. I guess I'll start by saying that when I hear people describe the New York Health Act and the upsides of it, I understand why people like the idea. I mean, you're talking about covering everybody for everything, no premiums, no deductibles, no copays, no network restrictions, no prior authorization, and we all save tens of billions of dollars. I guess my argument back is that I don't think that's how it would work. If you apply what the law says to the actual reality that we're dealing with, there are certain things that have to be accomplished. One would be that you have to change the health plan of every single person in New York State. It's 20 million people. They would no longer be members of Medicare. They would no longer be members of a private health plan. They would no longer be members of Medicaid. They would all have to be enrolled in a new plan now operated by the state of New York. Whether they want to or not, it would be mandatory. As Mr. Gottfried just said, part of the idea of this is to get everybody in the same boat. That, in and of itself, is a big logistical task. I think we all remember how rough it was when Obamacare rolled out. I will say right here, I was a supporter of Obamacare. I remain a supporter of Obamacare. But no one can deny that it was a very rough transition. There was a lot of tumult. The party control of Congress changed partly as a result of it. And that was nothing compared to the logistical challenge that we're talking about in the New York Health Act. The second big thing you have to do is you have to change the entire system we have for collecting money to fund healthcare. You're going from a mixture of taxes and premiums to an entirely tax-based system. Depending on your estimate, the tax increase necessary would be somewhere between doubling and tripling the total revenue of the state. And that was before, I now understand that they're going to be adding long-term care, so that's another $20 billion or so. It's an enormous tax hike, the likes of which that this state or any other state has never contemplated. The top marginal rate would be about triple what it is now, so close to triple what it is now. And we would also be, our top marginal rate would be roughly 3 times as high as any other state. So whatever competitive disadvantage there is in having the highest taxes, we would be going into uncharted territory. The third big thing you have to do is you have to totally reorganize how providers are paid. We have very complicated, I will acknowledge, very complicated and probably flawed system for reimbursing providers, but it's the one that they've been depending on. That would be more or less starting from scratch. You would be going from a system that pays some providers better than others to a system where everybody's reimbursed on according to a single set of rates. Now, for a hospital serving an impoverished neighborhood that doesn't get a lot of private insured payments, that would probably mean more revenue. But for the The hospitals that currently do serve a lot of private insured patients who as a result have more resources, they're going to lose revenue under this scenario. And we're talking about the places that everybody thinks of when they think, this is where I want to go when I get really sick. New York Presbyterian, Memorial Sloan Kettering, these are very expensive, high-end institutions. And depending on how the reimbursement works out, it seems unlikely that they're going to be able to maintain their current level of spending on salaries and equipment and technology. The fourth big thing that I see as an obstacle is that you're going to be putting all of this money and all of this responsibility and all of this power in the hands of a single organization known in the shorthand in New York State as Albany. Albany is not known for being a crackerjack manager of programs. It's not known for being efficient. And frankly, with all due respect to the many people in state government, and I include Mr. Gottfried in this, many people in state government are honest as the day is long and hardworking and well-intentioned, but not everybody in state government is. We all know that. And that would inevitably filter into the management of the healthcare system. Part of my concern about this is that the bill lacks a lot of specifics. It does not spell out the tax rates or the brackets. Understandably, because we don't know what it would cost. That's another blank. We haven't had a formal official study of what this would cost. We had the work of a professor at UMass Amherst. We had a very good study that was sponsored by the New York State Health Foundation. But that study assumed that we would get federal waivers. So it's sort of starting off with, we've now just heard from the sponsor that we're no longer assuming that we'll get federal waivers. That changes the cost considerably. I've rattled off what I think are the principal concerns. There are hundreds, if not thousands, of smaller issues that would inevitably crop up, unintended consequences, unanticipated glitches. A lot of the benefits of this are predicated on the idea that it would save billions or even tens of billions of dollars compared to the status quo. I don't think that's clear at all. When the Urban Institute looked at the Bernie Sanders Medicare for All plan, they actually anticipated that it would increase national health expenditures by 16%. Why is that? Well, you're taking away the cost controls that exist as they are now are what we know as copays, deductibles, networks, prior authorization. They may or may not be very effective. We're a very high-cost country. But if you take them away and you don't replace them with anything else, and you have 1 million more people with insurance, you can expect spending to go up, not down. The one thing that would be standing in the way of higher spending would be the willingness of state officials to drive a hard bargain at those negotiations with providers. Now, the one group I would expect them to drive a hard bargain with would be the drug companies. Everybody likes to beat up on the drug companies, and maybe for good reason. But I'm here to tell you, after paying attention to state government for a long time, that the general mode among elected officials in our state government is that they want to spend more on healthcare. They campaign on it. They brag about it in their constituent newsletters. Healthcare hospitals and healthcare unions and other providers are among their biggest campaign supporters. The general attitude of elected officials in state government is more money means better healthcare. And so if you're expecting that elected officials with that mindset are suddenly going to be the ones who are cracking down and controlling healthcare costs, I think that's wishful thinking. I guess I'll close with the point that often gets made. In the last few years, we have come closer to universal coverage than ever in the history of the state, where it's used to be 10 or 11%, now it's 5 or 6%. I guess I would add to that a lot of the remaining uninsured are actually eligible for free coverage right now. A lot of them are very low income, and they would qualify if they wanted to. They could sign up for Medicaid or they could sign up for the essential plan. Why they don't, I mean, there might be a lot of reasons. Those reasons would still exist if there was single payer. So you're going to have, you're not necessarily, just the simple fact of moving to single payer doesn't like make the uninsured problem go away. But I guess what I was saying, if you wanted to wipe out that uninsured problem, or if you wanted to close other gaps in the system, there are incremental steps you could take that would cost nothing close to the $139 or $159 billion the single payer plan would cost. As Mr. Gottfried just said, the real focus of this, most of the money we're talking about, most of the disruption, most of the effort, most of the political capital that would be invested is not about the needy part of this society. It's not about the people who are uninsured. It's about the people in this room who have insurance. Maybe they're not happy with it, but you're throwing a lot of money and a lot of resources at people who have insurance, people who by and large are affording it, and you're not even giving them the choice of saying, no, I'm going to keep what I have. So that's my I don't know if it was 8 minutes, but it was my short version of my spiel.
Thank you. We're not measuring everyone's time so precisely, but I appreciate that. And I think now we'll just turn it over to Dr. Fein, who I think has a different perspective from Mr. Hammond.
Yes, okay. So I sit here before you as a practicing primary care general internist, a medical school professor who teaches medical students, and the chair of the New York Metro chapter of a group called Physicians for a National Health Program. I am on this panel, I suppose, to represent an increasing number of physicians who favor a national health plan in which all Americans would get their health insurance from a single government plan. That's the way the survey was worded. That is sometimes referred to as an improved Medicare for All plan. This month, the Kaiser Health Foundation reported that 56% of physicians supported such a single-payer plan. And I can tell you from teaching medical students and medical residents, an increasing number of them favor single-payer. In fact, all 9 medical schools in the New York metropolitan area have a student chapter of Physicians for a National Health Program. So why are a majority of physicians beginning to favor a single-payer reform? Well, to paraphrase Uwe Reinhardt, it's the system, stupid. He said it was priceless, but a system that does not have universal coverage, guaranteed access to care, that puts profits before patients, and that does not view healthcare as a human right is a system that contradicts the fundamental reason that many of us physicians have gone into medicine. We aspire to help others. Single payer is based on the principle that healthcare is a human right. It guarantees universal access to health and medical care, and many physicians find that our present financing and delivery system does not live up to these goals. Now, the problem is not just that we have 28 million uninsured in America, or 1.2 million here in New York State, but we have an epidemic, I think, of underinsurance, with increasing premiums, deductibles, and co-payments. And because of our multi-payer, market-oriented payment structure, the for-profit private health insurance industry has established mechanisms to compete with each other, such as prior approval programs, deductibles, and copays. The market model says we need these financial barriers to care in order to control demand for services. But these barriers not only harm patients who delay seeking care until they become so sick they have no choice, but they also hurt doctors. For example, there is the prior approval process. Just last week, I spent over an hour on the phone with a for-profit prescription drug benefit company trying to get a prior approval for an antihypertensive medicine for my 94-year-old patient. He had been on the same medication for over 10 years, but the pharmaceutical company had changed its classification, the classification of that medicine, from a tier 1 to a tier 3 medication, which it claimed cost them more. If I wanted to prescribe the tier 3 medication, I was required to get a prior approval. My patient had a moderate memory disorder. I just could not justify changing him from his previous medication to a new medication that looked different and might confuse him, resulting in his stopping treatment. But it took me 65 minutes on the phone to accomplish this task. The administrative cost that physicians and their staff spend interacting with health plans is really outrageous. Larry Casalino from Weill Cornell's Department of Health Policy and Research conducted a survey of Canadian and U.S. physicians and found that physician practices in Ontario, Canada, spent $22,000 per physician per year interacting with Canada's single-payer agency, while U.S. physicians spent $83,000 per physician per year, 4 times as much, dealing with health insurance companies. Nursing staff in U.S. doctors' offices, including medical assistants, spent 230 hours per physician per week interacting with health plans, nearly 10 times that of their Canadian counterparts. If U.S. physicians had administrative costs similar to those of Canadian physicians, the total savings would be approximately $38 billion per year. It's not just physician offices. When hospital administrative costs are compared, including salaries for staff who handle coding and billing, about 25% of all U.S. hospital spending consists of administrative costs, compared to 12% in single-payer Canada. For-profit health insurance companies have to maintain these billing and collection administrative costs in order to compete with each other. If one company doesn't deny claims or require prior approvals, its profits will drop. Single payer eliminates cost barriers at the time of service. No copays, no deductibles. The market-oriented economist claims that without cost barriers at the time of service, the demand for services will go through the roof. Waiting lists will grow. But the experience of Medicare in 1965-66 was that over 16 million previously uninsured folks over the age of 65 enrolled in Medicare within 1 year, and there were no waiting lists. Well, add to these time-consuming activities the electronic medical record. Well, I happen to like the EMR because I can see the notes of my consultants, retrieve the laboratory results easily. However, I have trouble entering the patient's history and physical exam on the computer while talking with the patient. As a consequence, in order to maintain eye contact with patients, I don't enter a complete note in the chart while I'm seeing the patient. Frequently, I end up staying after hours or carving out time on the weekend to finish my notes. Little wonder that an increasing number of physicians are experiencing, quote, burnout. Some surveys indicate that 46% of physicians report burnout. The suicide rate for physicians is higher than the average suicide rate in the U.S. Sure, some of this relates to the doctor's world of dealing with pain and sickness and death. However, the Journal of Hospital Administration lists some other factors. The hassle factor, insurance company methods to wear down providers to minimize payout for coverage, adversarial financial incentives to insurance employees to deny care to patients, obtuse non-scientific criteria for pre-authorization of care, for-profit CEO salaries in the millions. Bertolini, former president of Aetna, received $159,000 per 8-hour workday. What? Healthcare as an investment vehicle. Shareholders are more important than patients. I believe that the New York Health Act will deal with these problems that lead to what is increasingly called moral injury of doctors, nurses, and other providers of health care to patients. The legislation states that, quote, all payment rates under the program shall be reasonable and reasonably related to the cost of efficiently providing the health care services and assuring an adequate and accessible supply of health care service. Until and unless another payment methodology is established, health care services will be paid by a fee-for-service basis, similar to what exists today. The New York State Academy of Family Physicians has passed a resolution endorsing the New York Health Act. The New York and Kings County medical societies are considering supporting the act. The New York Health Act, I think, will benefit both patients and doctors. Thank you.
Thank you, Dr. Fein. And for our last panelist, Eric Linzer, may have something to say about the administrative burdens imposed by insurance companies, perhaps, but I'll leave it to him.
Well, I appreciate the opportunity for the bar to have me here. We certainly have covered an awful lot of ground since we started. So good afternoon. I'm Eric Linzer. As mentioned earlier, our health plan members provide coverage to over 8 million New Yorkers. And these are folks that get their coverage through an employer, both large and small, as well as individuals who may purchase their coverage on their own or either through the exchange or directly through a health plan. And then the millions of New York residents who are covered through the various government sponsored programs. So when you talk about the folks that the plans that would be affected under this and an elimination of basically all health insurers in the state, you're talking about folks who work with a wide variety and a broad breadth of folks across the state. I'll agree with the panelists, the other folks on the panel that every New Yorker deserves access to high quality, affordable healthcare coverage. I think the question is, how do we get there? As Bill pointed out, New York is well on its way to getting to universal coverage, moving from 10% uninsured in 2013 and down to less than 5% today. And a big part of the reason why New York has been able to get there has been the work that our member plans have done in implementing both the Affordable Health Care Act, but also the work that's going on at the state level around Medicaid redesign and reform. So, without the plans, I think New York would be in a much different place as it relates to where we are around getting to and achieving that goal of universal coverage. On the notion around, or on the discussion around the New York Health Act and moving towards a government-run single-payer system, I think there's, Bill certainly touched upon a number of the concerns that we would have. I'm going to focus on, really three areas. One is around the tax increases. Second is the uncertainty around some of the financial assumptions. And then finally, focusing on some of the issues that would have affecting the delivery system. So, to Bill's earlier point, there have been a number of analyses that have looked at what the cost of moving to a government-run system would be here in New York. And I think the best analysis that's been out there is from the New York State Health Foundation, which back in July provided an independent analysis of what it would cost. I think the biggest takeaway from that are, a couple things. One is, the massive tax increases that would be required to fund this. And I understand, there's different viewpoints of taking the money from premium collection and replacing it with tax increases. But the fact that, this would essentially more than double the state budget, I think should be concerning to a whole host of folks, partly because of what that means to New York's competitiveness and what it means to the economy. But also the fact that the Health Foundation's analysis included a number of really big caveats in there that I think creates some level of uncertainty around the prospect of that $139 billion going even higher, and recognizing that number didn't include the issue around long-term care. Some of the assumptions that were made were certainly whether or not the state would be able to get the necessary waivers. And while I think there's a legitimate disagreement on whether or not waivers would be required, the fact that New York gets $40 billion from the federal government to help fund our Medicaid program and the Essential Plan, and the fact that CMS Administrator Seema Verma said this past summer that states that look to move to a single-payer system would not get funding from the federal government, I think really calls into question not just the state's ability to move in this direction, but what happens to the future of that $40 billion and how the federal government is going to think about the support it provides to New York. The other piece here is, some of the other big caveats in that report talked about the reimbursement rates to doctors, hospitals, and pharmaceutical companies. So, and that $139 billion tax number was all predicated on the state's ability to generate savings from or reducing the rate of reimbursement to those folks who provide care and to the pharmaceutical industry. The inability to get those reductions, only calls into question whether or not the state would have to continue to raise taxes even higher. And I think those are legitimate issues that need to be discussed, need to be recognized, especially when you think about prescription drugs. So New York has the ability to try and extract additional rebates from pharmaceutical manufacturers right now, but it's a challenge. I mean, if you've got a large pharmaceutical company that chooses not to negotiate and discuss whether or not they're going to give the state additional rebates, or in this instance, discounts, it really calls into question the ability of the state to provide access to those potentially life-saving drugs. The best example I would give you, recently as it relates to New York, is the example with Vertex and its CF drug Orkambi. New York has tried to extract additional rebates from that drug manufacturer. Vertex has politely declined. And when you look at the example in other countries, such as in Britain, the British system has taken a similar approach, viewing that the cost is too high, but has gone one step further and denied access to that. So I think it becomes a real challenge as to, if you can't get the reimbursement rates, or if you can't push down the reimbursement rates, one of two things is going to happen. Either you have to increase taxes to be able to fund those costs, or second, the potential to prohibit access to certain drugs, services, procedures, and the like. I think the other big concern comes to what this means for the delivery system. And I mentioned a bit about the lower reimbursement rates to doctors and hospitals, and the state's health foundation indicated that those lower reimbursement rates may encourage doctors to start to leave the state, partly because they don't want to be reimbursed at lower rates, and I think that's a legitimate concern for folks to have. Further, the Health Foundation did note that the increased consumer demand wouldn't fully be met. So, as much as folks don't want to talk about other countries or wait times, I think the wait time issue is a legitimate concern for folks, especially in light of the foundation acknowledging it as a potential issue as we move from the current system that we have today to potentially a government-run system. I mean, I think you look no further than north of the border to Canada, and the Fraser Institute, which is a nonprofit, independent research entity organization that has looked for decades at the Canadian healthcare system. And one of the defining characteristics of the Canadian system is longer wait times. And this isn't just for elective procedures, but these are for some basic diagnostic issues. So, for example, median wait times for a referral by a general practitioner to a consultation with a specialist run about 10 weeks, whereas the median wait time to get to treatment is close to 20 weeks. Now, obviously, those wait times are going to vary depending upon the specialty and the service, but when you think about some basic diagnostic technologies, MRIs, CAT scans, ultrasounds, it's on average, it's about 10 weeks for an MRI in Canada, over 4 weeks to get to a CT scan, and nearly 4 weeks for an ultrasound. And I don't think these are the types of things, the wait times that New Yorkers would be accustomed to or would want in their healthcare system. I think the other piece here is, and Bill touched upon this a little bit, is the lack of choice that you're giving New Yorkers. I think the concern becomes when you think about Medicare, public sector employee unions, folks who may get their coverage through their employer. One of the challenges that we saw with the Affordable Care Act is the promise of, if you like your coverage, you get to keep your coverage. And we know what happened when folks realized that they weren't going to be able to keep their coverage. So there is growing concern, I think, among folks as they start to dig into this and understand that their coverage, the coverage that they currently get today would no longer be available to them. Back in November, public sector employee unions in New York City had raised concerns about this very prospect, and I understand that there may be further conversations ongoing. But if we start to carve out exemptions, I think it begs the question of what have we really done to disrupt the coverage of 20 million New Yorkers to get to something that may not necessarily get us where we want to be. I think the other piece here, this touches a little bit upon the tax issue, is the sustainability of a government-run system. As Bill touched on this, I mean, the massive tax increases that would come with this, and the spending that this would result in, really has the potential to squeeze out other priorities, education, transportation, and infrastructure. And while the economy has been relatively good and has been trucking along for a number of years at this point, I think we go back no further than 2001 when the state's economy really took a hit, and it begs the question of what happens when tax revenues don't meet projections. And regardless of whether you have a separate trust fund for health care, it does create some questions about other state priorities that we may have. So where does that leave us? I think from where HPA and my members sit, the fact is that our collective efforts really should be to be focused on building on the current infrastructure, working on things that focusing on the things that are working well, working on the things that addressing some of the challenges in the system. And I certainly recognize that administrative issues are something that does need some work. That said, moving to a government-run system doesn't take the administration of healthcare completely down to zero. There's still significant costs that come with that, And at the same time, I think it's important to recognize that any administrative savings that you get from eliminating private health insurers from the marketplace aren't going to be sufficient to cover the cost of the New York State Health Act. Instead, I think the focus ought to be on, taking steps to, as Bill pointed out, reaching out to those folks who are eligible for services, but also doing things that will, help better stabilize the marketplace, and ultimately focusing on those things rather than, disrupting coverage for tens of millions of New Yorkers, when really the focus ought to be on closing the gap on coverage and trying to improve the current system. So with that, I'm happy to take part in the panel and engage in the Q&A portion, Brian.
Thank you so much. I think one issue that I think cries out for further discussion is whether we have an agreement among the panelists as to whether there's a need for a universal health care system. The statistic, the Assembly Member Gottfried noted that the uninsured rate is down to 5% in New York State, and that compares favorably with the nation. But by the same token, the insured population has co-insurance and deductibles that could often be an impediment to coverage. I'm not sure that, I just want to understand, do all of us agree that there is a need here for some radical transformation of the system, A, in light of the 5% uninsured rate, but B, in light of the continued cost-sharing amounts, as well as the administrative hurdles that some members would have to overcome. And on that point, on the last point, with regard to with prior authorizations, I think that couldn't the current system be tweaked, so to speak, to address the issues over prior authorizations, at least for certain preventive services? And wouldn't that remedy the issue as opposed to introducing a new system that would replace the existing coverage for millions?
Well, first of all, for everyone, and the fact that everyone says, oh, I agree that we should have universal access to affordable quality health coverage, I'd be astounded if I ever met anyone who said, no, that's not true. But that's like saying everyone agrees we should have racial justice in America and we should have full opportunity for women. The fact that everyone might say that doesn't mean that, well, I guess we can shut down the State Division of Human Rights, and since everyone has agreed with that slogan, we can check that box and move on to some other issue. Because unless you've got a proposal for how to do that, a proposal that can then be critiqued and see whether it actually does anything, reciting that slogan doesn't get us anywhere. And there's no proposal that's been made today or any other day that meets the needs of New Yorkers. The notion that, take for example, well, why don't we just say we can't have prior authorization anymore? See whether the New York State Association of Health Plans would sit still for a proposal that says they can no longer impose prior authorization. Yeah, that would be a great day, except that wouldn't apply to the more than half of New Yorkers who have commercial health coverage who get it through a self-insured plan, because we can't tell self-insured plans legally that you can't have prior authorization. And if you want to go through all the bad things that insurance companies do and say, well, we won't let them do that anymore. We won't let them eat up 18% of the premium dollar. We won't let them have restricted provider networks. We won't let them have prior authorization. We won't let them be in charge of deciding how much doctors and hospitals get paid, or or what services they're allowed to provide. If we do all that, why do we need them? What value do they add to the system if they're not doing all of that? And by the way, if they are doing that, all of those things, I don't think they would sit still for enacting that kind of legislation. But the basic question would be, if we take all that away from the insurance companies, why do we need them?
Yeah, so Brian, I'm going on your question about do we need radical reform? I think the fact is, I think reform is needed, but I don't think we need to throw out the entire system. So when you think about let's start with who the uninsured are. And there's three big buckets. One are, as Bill pointed out, folks who are eligible for existing state programs but aren't enrolled, and there needs to be more done more there to get those folks enrolled. Second, are folks who make too much for existing federal subsidies, but not quite enough to be able to afford coverage on their own. So that folks between 400% and 600%, and there should be steps taken to provide additional subsidies at the state level for them. And I think third is the issue of undocumented immigrants, and that's an area where I think the state is still challenged there. So rather than, so first I think the step is to sort of deal with those different populations and providing options for them, and there are steps that can be taken. Providing some flexibility in the marketplace for products that encourage consumers to be able to share in some of the savings. I think, like I said, being able to provide some sort of a state assistance or state APTC type engagement for those folks in the 400 to 600% of the marketplace. And then, as far as the issues that Assemblyman Gottfried bring up about administrative costs. I mean, first, I'd like to kind of correct the record that it's not 18%. I mean, health plan, administrative costs for health plans are typically about 11%. And that, remember, includes a number of things such as regulatory reporting. It includes taxes such as the $5 billion in HICRA taxes. And while there is some, roughly a 2% profit margin for most of those plans, it's certainly well below the 18% that the chairman continues to reference. That being said, I think some of the administrative processes in place, are important. Prior authorization is important. Getting rid of prior authorization, I think, creates the, further potential of wrong care, wrong place, wrong time. Prior authorization is there in part to ensure that the care that health plan members are receiving is coordinated, that it's not counterproductive, particularly in the prescription drug space. So I think there are a number of pieces there that to give them short shrift, I really think doesn't quite recognize the value that's brought to ensuring that we get that we're getting right care, right place, right time.
Could I ask a clarifying question? The phrase having consumers share in the savings, doesn't that mean shifting more of the cost of the health coverage directly to the consumer out of pocket?
No, what I'm talking, I know, there's a view from folks about deductibles, but also remember, Medicare includes deductibles in its coverage. So what I'm talking about is allowing for products in the marketplace where there's been a lot of emphasis placed on transparency tools. And if you're an individual who shops around, you're really trying to identify where the lowest cost place might be for particular shoppable services, MRIs, CAT scans, et cetera. But what's missing from that level of engagement for consumers is when they do find that lower cost alternative, shouldn't they get some of the benefit back? So this is not about, merely sort of shifting the cost onto the consumer, but allowing for the consumer to benefit in those savings and to encourage and engage them. Unfortunately, state regulatory requirements prohibit that those types of products. And when you look across the border, Massachusetts, New Hampshire, and other places allow for those types of products in the marketplace. And I think that's something that to give some benefit back to the consumer, and not just to minimize their out-of-pocket exposure, but also to reward them for thinking about where to best utilize those healthcare dollars.
Maybe after the program, you can point me to the insurance department, to the DFS reg that says you can't reward customers that go out and find a cheaper MRI.
It's not. It's an interpretation of the anti-inducement statute, Mr. Chairman, and I'm happy to have a conversation. And we've got some ideas on maybe ways to tweak that I'd love to work with you on.
Well, I'd be interested in seeing that and then being able to then see what the actual implications of that kind of thing would be in the real world on consumers.
Sure. I think it's probably useful to think about what prior authorization means. It's basically if you were to just pay every bill that came in, you would be opening yourself up to fraud and abuse, and also just ill-advised care. You'd be paying. Not only would the ill-advised care be happening, but you'd be paying for it, whether it was actually good for the patient or not. And so all health plans, both private, public, for-profit, not-for-profit, have systems in place to catch care that looks like either it's unusually expensive or it doesn't seem appropriate for the patient, and the classic example is ordering a brand name drug when there's a generic equivalent. And sometimes the price difference can be huge, and the efficacy of the two medications for most patients is exactly the same. And so when a provider requests the brand name drug, which is going to entail a significant additional expenditure, it triggers some process. Not being a provider, I've never had to deal with it, so I can empathize with your pain. But in some cases, it's probably really irksome and maybe even a waste of people's time. But in other cases, you're steering people towards a less expensive, equally effective alternative. And part of the reason this is necessary is that everybody involved in the healthcare system is human, and they're subject to errors, they're subject to undue influence. There's been a lot of documentation about how drug companies will go out to providers and they will sweet talk them, they will give them junkets, they'll give them paid consultancies, and those same providers will start prescribing the brand name drugs that company markets. We saw it with opioids. We've seen it with any number of drugs. And so I think there's this constant tension between the provider community and the payer community trying to keep a lid on that kind of stuff. It's not, maybe there are abuses of it. I'm sure there are. And maybe for-profit providers are more ruthless about it than other payers, but it's part of every system. And so the 18% number, as Eric says, it's high. That's kind of the maximum of what administrative costs can be. Excuse me. A lot of it is necessary bread and butter stuff, making sure that the person's actually enrolled in the plan, making sure that the doctor's qualified, making sure that the care is warranted, making sure the care was actually delivered. And so all of that stuff has to go on, even if it's the state running it. The prior authorization call, I know that it's often said, and I think I maybe even said it, that the New York Health Act doesn't have prior authorization. But I haven't found it in the text of the bill itself. And I've heard Mr. Gottfried say recently that he's been contacted by the Medical Society, and the Medical Society has asked him to add language to the bill regarding prior authorization. And what it says is that the prior authorization could be no more onerous than what currently exists in Medicare, if that's correct. Mm-hmm. So there is prior authorization in the New York Health Act. There inevitably will be. And there's inevitably going to be situations like what Dr. Fein just described, where it's going to be annoying and the person on the other end of the phone is wrong, but it's going to happen anyway. It's just going to be somebody in Albany instead of somebody at a health plan.
Thank you. I think we have 12 minutes, and I want to give anyone in the audience an opportunity to raise a question. We have a roaming mic here, so we'd welcome any questions. Sure. You just press this.
So one of the things that struck me here is there's the concept of health care and access to health care and the provision of health care on one side. Then we have the concept of on the other side of insurance. And some of the arguments here, what I really want to understand is, how is insurance coverage, when you look at insurance coverage as the primary reason for its own existence, is very different than looking at health care and the provision of health care as the primary reason for its own existence. So when we look at philosophically healthcare as a right, meaning that people should have access to healthcare, and that falls within sort of the ethos of the United States and equality and access, equitability. But then on the other hand, insurance in of itself is a financial vehicle that can be used as an instrument to help individuals gain access to healthcare. The survivability, and I'm not saying we should take away the jobs of the insurance industry, but are we here talking about fighting to save an industry versus how are we going to ensure that New York citizens or citizens at large in the United States or people in the United States, depending on your viewpoint, actually have access to that care? And can that care be delivered effectively? And can the access be there without insurance? And when we create a universal program, what we're doing is, it seems like, and it's sort of eye-opening for me, is what Dr. Fein talked about is the creating healthcare as a financial instrument. And is that really where we want to go? Because then the insurance companies are competing with one another for the benefit of the shareholders, which I don't know that we have a right to take that away from a business. So can healthcare survive without insurance? And if it can survive without insurance, what would that model look like? Or is it absolutely necessary? And I'd like to hear maybe from either Eric or Bill, and then either from Assemblyman Gottfried or maybe even Dr. Fox. Just the two viewpoints. So I'll let you pick the one.
Yeah. Only because this is being video recorded, I'm going to repeat your question and because it wasn't necessarily picked up. I think Tina's question is basically, in order to provide access to healthcare or improve access to healthcare, is the provision of health insurance through private insurers necessary to achieve that goal?
That's a lot better said.
Yeah, so I guess I'll take that. I think the short answer is, health plans are here to help both in the financing as well as the coordination of healthcare, Tina. So, at a time when, again, we've got 95% of New Yorkers covered, the focus really ought to be, on how do we make sure that we're able to promote a system that doesn't unnecessarily disrupt the care and coverage for New Yorkers. So
The one question I have is, like, coordination of care, it's not necessary to be done through an insurance company. If you talk to a physician, they would rather
But there's still, no, it's not just financial, Tina, because you do have health plans that do have care managers to make sure that individuals, particularly with acute and chronic conditions, are getting the services that they need. And while a physician, may work within his or her office, there's going to be other touch points. I mean, I think the one thing that we recognize is that, care can be disparate. And I think where the plans play a role is making sure that there is coordination across the continuum for those patients. And the other piece is from a population health management standpoint, if you're a physician practice or even an institution like where you work in Montefiore, you have a smaller view of the system than a health plan may to be able to look at population health issues and trends. So there is a significant role that the plans play, both in the financing of healthcare, ensuring that we're trying to make the best use of finite healthcare dollars across the system, but also ensuring that consumers are getting the care that they need, particularly if you're an individual with a chronic condition. And remember, it was health plans, not the government, that were the entities that the ones that had developed care coordination type services for asthma, congestive heart failure, and also were the entities that that brought prescription drugs into the coverage aspect. It took Medicare over 40 years before it started covering prescription drugs. So I think both from a care, a coordination, an access issue, but also looking at innovation. I think the private market plays a better role than allowing government to try and figure this out for us.
Well, I would say, first of all, having health insurance is better than being uncovered entirely. Duh. But if some payer is going to be looking over my doctor's shoulder and saying yes or no, or trying to steer my doctor towards one thing or another, I would much prefer that somebody be publicly accountable rather than accountable to its stockholders who have no connection to me. And I not only want them to be publicly accountable, but I'd want to know that that whatever they do not only applies to poor people or older people, but applies to all 20 million of us, because they're much less likely to be rude to me and my doctor and you and your doctor if they are also looking over the shoulder of Mike Bloomberg's doctor and Governor Cuomo's doctor and all of our campaign contributors' doctors. That's where the all in the same boat issue comes in.
So if I can jump in.
And I've never heard anyone suggest that the notion of trying to do care coordinating as opposed to gatekeeping and trying to guide people towards more effective as opposed to just cheaper for stockholders healthcare, I've never heard anyone suggest that we should thank the insurance industry for that development. And in terms of coming late to the game with drug coverage, there was a time when almost no health insurance covered drugs. That really is a fairly recent development. Yeah, it took time for Medicare to jump on board, but those of us who are old enough to remember health insurance a number of years ago remember when drug coverage was an unusual thing.
Just as a footnote, Montefiore has been doing care management for 40 years, so there are healthcare providers that have full capacity to do that, and we do partner with insurance companies just as
So yeah, I'll just jump in and sort of respond to some of the points that have come up. I think, again, sort of going to the international comparative perspective, I think the U.S. is rather exceptional in, its reliance on private health insurance coverage. Pretty much every other advanced, certainly high-income country, but also many emerging economies have moved in the direction of some form of universal coverage. It may be single-payer or it may be a regulated multi-payer type model, which would still allow for some competition. So I think there's many sort of different hybrid ways that we could approach this. But I also think that some of the comments, interestingly about, even that Bill Hammond made, that, government has to do the same kinds of things, right? Even they would need some kind of pre-approval process. Really, at the end of the day, the difference maybe isn't so great. So yes, that does point to, do we really need the private health insurance market when government also performs those functions? But, I think we also maybe tend to overstate, just how equitable some of the, public plans are. There are many plans that, public plans that do have copays. And actually, so coming back to, I think the initial question about, do we all agree that, we need a universal health coverage system? Clearly, I think we don't all agree that we need a universal health coverage system. But what I also want to point out is that I wouldn't call single payer radical. Okay. Certainly in a US context, single payer is considered radical, and it's been adopted by the left as, a very radical position, considered to be a very radical position. But, if you sort of look in international perspective, the kinds of people that actually or groups that are advocating for single payer or have adopted single payer internationally are not really that radical. For instance, the World Bank is now recommending that all developing countries move towards a national health insurance model, or at least towards universal health coverage, and they're sort of privileging the single-payer national health insurance model. We don't typically think of the World Bank as a particularly left-wing group, right? In countries that have adopted single payer, even in Mexico, it was sort of initiated by a technocratic wing in the Ministry of Health. And, it was opposed by the far left parties because they wanted to expand, a national health service. Is this a really radical perspective? I think most countries that have single payer, they, as I said, have, a sort of parallel private insurance market that, does allow for some additional room for, private insurance, but while ensuring that everybody has a basic floor. So I'll leave it at that.
Does anybody else have a question? I just want to follow up, and this is a point, I think, of disagreement perhaps between Assemblymember Gottfried and Bill Hammond, is whether the political administration of health care coverage, in this case through the Department of Health, would make the plan more or less accountable for cost containment and access to care. And just to play the devil's advocate, so to speak, isn't having a competition among health plans, and even perhaps a profit incentive to innovate ways to better coordinate care and to contain costs at the same time? Isn't that a vehicle for achieving the goal, subject to, I would believe, should be strict health regulation? So I'm just proposing that there's a different perspective. I think the Department of Health, even officials too, can be subject to the influence of lobbying as well as the legislature, and so maybe there's a disagreement about the role of competition and private enterprise in the provision of health care in New York.
Because the insurance companies succeed when they spend less money on your health care. They don't succeed by investing in you being healthier, because under our current competitive quote-unquote system, the insurance company knows that a few years down the road, you'll probably be the customer of one of their competitors. So if they spend money today making you healthier 10 years from now, they know that their competitor will be the one sharing in the fruits of your healthiness. That's not a market mechanism that induces an insurance company to make you healthier. And just like any number of other for-profit companies, that because of the way our economic system operates, lots of companies are focused on their short-term bottom line and returning as much money as possible to their investors. They're not incentivized to spend more money on selling you a better product or making you healthier in this case. They're incentivized to sell you as cheap a product as possible, or a product that looks cheap by lowering the premium, but whacking you at the other end with deductibles and restricted provider networks that you don't notice when you're looking at the price list and deciding which policy to buy.
Yeah, I think this is where we're going to fundamentally disagree on things. Just a couple of thoughts on that is, first and foremost, this notion that health plans do better when we deny care couldn't be further from the truth for a couple of reasons. First and foremost, we have strict state guidelines around the portion of the premium dollar that has to be spent on medical care and limits on profits. So, and if we miss those targets, health plans are required to reimburse employers and consumers for the cost of missing those targets in state statute. Second, this notion that somehow health plans are unaccountable when we have standards in state law around internal grievances, external appeals, to give consumers the ability and providers the ability to appeal those decisions. I think where the concern comes in with a state-run system is, who's accountable in those instances. And then finally, as far as investment in health and wellness, a big part of the move from fee-for-service to value-based contracting, which health plans were doing in advance of the state getting into this space, is designed to focus on health and wellness, as well as programs that plans have in place to keep you healthy. So this notion that it's bring them in, keep it cheap, dump them off, I think is a gross mischaracterization of how the industry currently operates.
Has anyone ever seen a TV ad for a health insurance company that said, if you have a chronic condition, if you have COPD, if you have heart disease, if you have diabetes, we will take better care of you than our competitors? You have never seen that ad, and you never will, because the insurance company prospers if the people with diabetes and the people with heart disease say, my insurance company is treating me terribly, I'm going to go inflict myself on their competitor.
We are a little over time, but I want to give Bill Hammond an opportunity to respond, and I think you may have the last word.
Okay, I'll keep it short. I would just say that there are perverse incentives in the healthcare business, and among the people who have them are the providers themselves. They, under a fee-for-service system, they have an incentive to provide more care. And so if they get it wrong the first time and their patient comes back, they get paid twice. That's what the incentives are. I'm not saying that's what the behavior is. And I think the same is true of the health plans. They have all kinds of incentives. That doesn't mean they necessarily act in a malign way because of those incentives. One of the problems I have with the New York Health Act is that it leaves the delivery system more or less intact, fragmented as it is. Health plans do a certain amount of stitching together the fragments because they have access to the patient's records regardless of what provider they went to. So they can spot redundancies, they can spot gaps. Maybe they don't do enough of that, but it's at least within their power. Under the New York Health Act, that would become the state's responsibility to spot those things. But they have given away a lot of the tools that would allow them to enforce that. They're saying, we're not going to restrict you to a network. We're not going to require, we're going to downplay prior authorization. And so let's say you're trying to do value-based payment and the way that works is you give a certain amount of money to a group of providers and you say, you're in charge of this patient. You figure out what he needs, what he doesn't need. And if you can make money on that, fine. The problem now is the state would go to a group of providers and say, here's $10,000 for Bill Hammond. And then Bill Hammond goes to a completely different provider. and the state's still on the hook for the bill at that other provider. So I don't see, it's hard for me to see how value-based payment is going to work unless the state comes in with a lot of the same tools that the private health insurance industry is using today. It's a weird note to end on, I guess.
Yeah, we're past 1 o'clock now, and I want to firstly thank our panelists for a very lively and informative discussion, and you know, particularly Assemblymember Gottfried for his response on some of the comments to his own piece of legislation, and to stand behind it, and all of the other panelists for their perspectives. And thank you for coming. And this event has been video recorded. It will be available, I believe, maybe 5 to 10 days, 5 business to 10 business days after the fact. So stay tuned for, you know, that notice. And thank you once again. And thank you, by the way, for Allison Sneeders and the others on our Health Floor Committee for helping. Thank you.